Not me, it's you.
All right. I want to welcome Dr. Reshamwala to speak to the pre-transplant liver group today. She's a board-certified gastroenterologist and transplant hepatologist with 10 years of experience. She's fellowship trained from the University of Maryland Medical Center in Baltimore, Maryland, and she's also received advanced training in clinical investigative research from the liver disease branches, National Institutes of Health and Bethesda, Maryland. She previously served as the medical director for transplant hepatology at the University of Maryland Medical Center prior to joining the faculty practice at the EMORY Transplant Center. Dr. Reshamwala has recently rejoined us from Southern California Liver Centers in San Diego, California, where she held the position of associate director. She has extensive experience in clinical trials. Dr. Reshamwala's current research interest includes management and new therapies for fatty liver disease and viral hepatitis. We are so thankful for you speaking for us today, and I will let you get started.
There we go. Can you see my screen?
Yes.
Okay, wonderful. Deb, thank you so much for that introduction, and it's great to see some familiar faces here. I am a transplant hepatologist at EMORY, and we go into transplant because we believe in the gift of life. We believe in donation, and we believe that patients deserve a chance to live a satisfying, fulfilling, healthy life after transplantation. And so the pre-liver transplant process is one that's very near and dear to me. And so I want to take you through it. And we've already had one, question related to this process. So I'll try to take you through it as clearly as possible. And certainly I'm happy to answer any questions. I'll just say I've practiced at maybe 4 different centers throughout the country. My husband was military before he retired, so we've unfortunately had to move a lot. And Georgia Transplant Foundation is an outstanding service. It's something that's not available at any of the other centers that I've been at, and they do provide hope, they provide help, they provide services, and I'm really proud to be here today, and I really thank GTF for giving me the opportunity to do this, because you guys do so much great work, and I've seen the difference that your work makes when I've compared to other places that I've practiced. So thank you, Deb. Thank you, GTF. All right. I'll start with some definitions, first of all. Many of you know this, so this will be quick, but sometimes we use the term cirrhosis and advanced liver disease kind of interchangeably. And cirrhosis results in over 34,000 deaths annually in this country, and that number has gone up since these statistics were published. In this country, 6th leading cause of death, but worldwide, it ranks between 3rd and 4th leading cause of death. OLT, orthotopic liver transplantation, is one term you'll see a lot as you go through this process. All the orthotopic means is that we take your native liver out, and in that same position in your body is where we place the new liver, which is different than in kidney transplant and some other transplants. So that's why we distinguish that. But it was developed as a procedure to prevent death from liver disease when medical therapy fails. And many of you know that there's not a lot of good medical therapies for many of the conditions that affect the liver. Dr. Thomas Starzl at the University of Colorado performed the first liver transplant in 1963, and that patient unfortunately died almost immediately because of rejection. We didn't have any anti-rejection drugs back then, just steroid medications. And as you all know, that's not sufficient to help knock down the immune response. So really, transplant remained experimental until the 1980s, where there was the development of cyclosporin. And cyclosporin is a drug that helps to prevent rejection. We have even newer drugs now. Cyclosporin is not the mainstay of treatment, but people can be on it. But we have even better drugs now. So in fact, the rate of rejection has gone down drastically over the years. So today I want to talk about what is cirrhosis and liver failure. I want to talk to you guys about who actually needs a liver transplant, because, I get referred patients and Just because a patient has cirrhosis, which we've defined earlier, that does not necessarily mean that you need a liver transplant. We need to follow you, we need to deal with issues and complications, but you may not necessarily need a transplant just yet. We'll, of course, spend a long time going through the liver transplant evaluation process and what that means for you and your family. Patients often, you'll hear your MELD score, we now use the MELD-sodium score, but you'll hear this term quite a bit, so I want to go over that with you. And then, let's talk about what we do while you're on the transplant waiting list. It's not just, twiddling our thumbs and waiting for an organ. We want to be active in your care. So those are the major things that I want to talk about today. And of course, any questions that you all have. So these are some pictures that I took off the Mayo Clinic website. I was actually going to put real photographs of liver specimens, but I decided that I wasn't sure if everyone could stomach that this early in the morning. So these are some drawings. And on the left here, you see a normal appearing liver. It's nice, smooth, tan, even texture, etc. And then on the right, you see a cirrhosis liver. So you see all these lumps and bumps and nodules and how the surface looks kind of lumpy, bumpy. When you look into the liver, if you were to take a slice of this, you see these structures, and these are blood vessels, bile ducts, arteries that kind of feed the liver and draw blood through the liver. And when you start getting inflammation and scarring, it happens around here, around these vessels, and then it kind of bridges to these other vessels. And so when the scarring bridges from here to here, you see what you develop. This is all scar in between liver cells. And so when the scarring happens, that cellular function is gone. Those cells are damaged, so they're not doing what they need to do. So you get this hard, scarred appearance. And if you ever look at any of your radiology reports, you'll notice sometimes the radiologists will comment that there's a nodular appearing liver. That's what they're seeing on their scans, this lumpy bumpiness. As I said, it's defined as a hard, scarred liver, but we can see some degree of improvement by treating the underlying cause. Now, this liver is never going to turn back to this liver, but we can see some improvement in the function of the cells by treating the underlying cause. So if a patient is actively drinking, when they stop, you can absolutely see some improvement of the liver function. And even the liver scarring, you can see some improvement. We can treat hepatitis. As you all know, we have great cures for hepatitis C and really good drugs for hepatitis B. So again, if we treat the underlying cause, we can see some improvement in the function. As you heard Rich talk about, cirrhosis can be asymptomatic and stable for long periods of time. He knew nothing other than he had the flu, but I guarantee you, Rich had cirrhosis doesn't happen overnight. He had this happening for a long time before he presented to the hospital with the hemoglobin of 3. So again, sometimes patients come in and say, well, why didn't my doctor catch this earlier? I certainly understand the sentiment, but if there's no symptoms and you don't go complaining of anything, or there's no abnormal blood test, it can be very hard to diagnose cirrhosis. But the issue with cirrhosis is that, yes, things can get a little better if you treat it, but you can also see the progression of damage, and you can develop problematic symptoms. And that's when what we call compensated cirrhosis turns into decompensated cirrhosis. So again, compensated cirrhosis was Rich before his hemoglobin was 3, and then decompensated was when he went into the hospital and they said, oh my goodness, you've had GI bleeding and all of these other issues. Now he's decompensated. So what happens? What are the things that you can see? And this group probably knows jaundice, the yellowness of the eyes. Ascites. Ascites is the fluid that collects in the abdomen. So as blood tries to flow back through the liver to get to the heart for circulation, when you have a hardened, scarred liver, that pressure is increased. So you get backflow of the pressure and you develop fluid in the abdomen. Patients can also develop, we use the term hepatic encephalopathy. I'm sure you may have heard your doctor refer to that term. This is the confusion that happens from toxin and specifically ammonia buildup, and it kind of goes into the brain and causes patients to act differently. And it can be something simple as being more sleepy than usual or word finding difficulties to full on, coma. So there's a wide spectrum of, what patients can present as. I have one patient who's an accountant for a Fortune 500 company, and his manifestation is he can't do the complex math and computation that he was very easily able to do before. He notices that it affects his high level functioning. Other patients have different manifestations. Some people even have sort of psychiatric manifestations like hallucinations and change in behavior. So it's really a spectrum of symptoms that you can see. Rich mentioned GI bleeding, throwing up blood or blood in the stool. This is what keeps me up at night because this is an emergency. We need to go in there, scope, take a look, treat what we can treat. In liver disease, people can develop varices. Varices are veins that are under pressure because of the liver, and they can happen in the esophagus, in the stomach, and even in the rectum. And a patient can bleed a lot from that. So that could be a life-threatening thing that myself or your other transplant hepatologist will come in and scope and take care of that. Many people will notice muscle loss. Again, I keep referring Rich's talk, but he showed you that picture. That was a powerful picture pre-transplant. Notice how his face was very thinned out. We didn't get to see, his torso, but his arms and his legs, I'm sure, were very thin with lack of muscle. But if he was keeping any weight, it was all around the belly with the fluid. There's a hormonal reason why that happens, because your body thinks you're in breakdown mode and it's scavenging muscle from other places for the normal functions of the body. But again, go to your liver clinic when you see your doctor, and you'll notice patients out there that have that particular appearance. You can get kidney damage, both from the medications that we give you, but also just because you have decompensated cirrhosis. Some patients have severe itching. That's more in certain types of liver failure, for example, primary biliary cholangitis or primary sclerosing cholangitis. But what patients will say is that they notice it most at night, and they're itching their palms and their soles, and they can't sleep. It's pretty impressive. And then fatigue. Fatigue is one of those things that patients will battle. I don't have an easy answer for it. It's related to, the muscle breakdown and having organ failure and all of the medications that you're on. And fatigue does go along with feeling cold. Typically we'll say good nutrition, trying to exercise. Rich was down to a 1/4 mile a day from 5 miles a day, but those sort of things will help keep you going as you wait for transplantation. I know that this is not a talk for my residents or fellows, but I just want to point out here, this is a graph that looks at life expectancy over the number of years when you look at patients with compensated cirrhosis and decompensated cirrhosis. And I'm not going to explain the statistics here, but you can clearly see that patients do better and live longer if they have compensated cirrhosis, as opposed to any of those other complications that we talked about in the slide. So we definitely in the transplant center need to be seeing all of you, but specifically if a patient has decompensated cirrhosis, you should be asking if your doctor has not already referred you to be seen at a transplant center. All right, so we've defined cirrhosis. We've defined that I want to see everybody, but if you have cirrhosis, and more specifically decompensated cirrhosis, we should put you through the liver transplant process. So let's go through that. So I think all transplant centers in this country should, but I believe they all do, have a multidisciplinary team approach to the liver transplant evaluation. And that's because we all play our own part and have our own expertise in your care. So you'll have a transplant nurse coordinator who is your best friend through this process. They are the ones that know the nitty-gritty about your details. They know, if you got admitted to a local hospital. They really do know everything about your care. And these folks are trained. They know what to ask. They know what to look for. And they really know how to advise you on transplant-related issues. Transplant hepatologist is me, my partners, my colleagues at centers across the country. And I like to think of myself as the quarterback for your care. When I see you and I see that you need something else, if you need a consultation with a diabetes doctor or a podiatrist, I help to coordinate that because I want to make sure that you're in tip-top condition as we go through this process. Of course, I will manage any liver-related issues pre-transplant, through transplant, and then lifelong, you'll be with me post-transplant. The transplant surgeon, certainly he or she are the ones that will be doing the surgery and you will meet them. It's a little bit, for any of the women out there, it's a little bit like an OB practice, right? When you had your children, you met your OB, but they might not be the ones delivering your baby because they're on call for 24 hours. So there may be a different surgeon who does your surgery compared to who you've met in your evaluation. And that's okay. You want somebody who's not been on call for 24 hours to be doing your surgery. So they do rotate. The social worker is also very key in your care. They will talk to you about your social support network, what to expect, and sort of the nitty gritty that you don't want to ask your doctor, but is related to transplant. We have a nutritionist. Rich mentioned the low sodium diet. I applaud him on doing that because I've actually tried a low sodium diet and I failed after a day and a half. It's a difficult thing to do. 2 grams of sodium is a very difficult thing to do. But not only will they go through the sodium restrictions, they'll talk about they'll give you other instructions on diet based on your needs. So if you're a diabetic with high cholesterol and you need low sodium, they're going to help you kind of craft a diet that's going to work for your needs. We have a transplant psychiatrist. There's a lot of emotions and feelings that go along with transplant, but also, there's a lot of coexisting mental health issues, depression, anxiety, PTSD, a lot of substance abuse issues. So our transplant psychiatrists are invaluable in helping patients get through the process and then long-term as well, if needed for the patient. We have a cardiologist, we have infectious disease members, we have a medical finance and insurance counselor. This person is also very key for you. And I didn't realize this before I started doing transplant 15 years ago, but there are so many ancillary causes and our insurances are so complex, right? You have co-insurance, you have co-pays, you have your deductibles. There's just so much that can be overwhelming. It's impossible to know what your out-of-pocket costs are going to be. And that's important. That's important for all of us. We all don't live in a bubble and we need to know what those numbers are so you can plan for yourself. Again, and then I can, depending on your needs, I can refer you to other specialists and consultants as needed. So really a multidisciplinary approach. The goals of the liver transplant evaluation are several. And first and foremost for me, it's about educating patients about liver transplant. If you think about the first time you went into your doctor's office, there's very few patients that really understand the extent of what we are embarking upon. And it's not going to happen in the first 1-hour visit that I have with you, but it's really our job to help you every time we see you to understand this process, understand about your liver, and all of the things that go along with it all the way through transplant. So education is very key here. Of course, we want to evaluate your liver disease, your causes, your complications. I want to look at your coexisting medical conditions. Is your diabetes out of control? Do I need you to get you to a diabetes doctor? Are you having chest pain? I need to look at that. So those are all considerations that are very important. We have to look at the anatomical and surgical considerations. So, patients sometimes say to me, why do we do so many scans? I'm always doing a scan every few months. So think of that as your surgeon's roadmap of what they're going to do for you, right? You go into a surgery, you want your surgeon to have a plan that this is what I'm going to do. This is where I'm going to hook up portal inflow. I won't use technical terms, but these are all things that they do for every single listed patient. They also need to know if you've had surgeries before. Have you had your gallbladder out? Have you had bariatric surgery? We're seeing a lot of that nowadays. They need to know that so that they can plan for their approach. There's a psychosocial evaluation. We want to make sure that mentally, emotionally, and as a group, you have the support that you need to make it through transplant. Rich talked about having to move and he went to Florida and thankfully his brother let him live with him and his brother's girlfriend. But imagine if he got the divorce and he had nowhere else to go, who would be his support system? So that's very important. We'll talk a little bit later about the nutritional evaluation and evaluation of your physical condition. Coordination of care, I cannot state how important that is. Again, you will need care from other specialties, and I would like, as the quarterback, I would like to get you there so that we can have a communication and they can let us know what their thoughts are and how your medications should or would change as we go through the transplant process. And then finally, there's a lot of feedback and communication with the primary team. So we understand, I know the list said that most people currently live around Atlanta, and that may be specific to this talk today, but most of my patients don't. They don't live here. They live 2 hours away, 3 hours away. So we recognize that you can't come to us every time there's a question or there's an issue, or if you call EMS, they're going to take you to your local hospital. So we strive to communicate with your local doctors to give them an update on where you are from a transplant perspective. That way, if there's an interval issue, they can either take care of it, or heaven forbid, if you need to come to Atlanta, you get really sick, we can arrange that transfer as well. So every time I see a new patient or every time somebody is listed or there's a new complication or issue, I call your referring doctor. I want them to know what's going on so that we are both on the same page. Very important. All right, so we know you have cirrhosis, hopefully not decompensated, but perhaps decompensated, which is why you are being evaluated. We talked a little bit about what the liver transplant evaluation is. The next step is, how do I get on the liver transplant list? So first and foremost, it may seem obvious to this group that you need a referral to a transplant center, but I do a lot of education, around the state of Georgia to primary doctors because they may not have access to gastroenterologists or other specialists in their area. So, I want to be very clear that even if the patient doesn't have decompensated cirrhosis, if you think they've got liver disease, send them to us. We will evaluate them. We'll give you recommendations. If they don't need to be transplanted, fine, but at least let's evaluate them, educate them, have the opportunity to treat them if needed, and then, we'll send them back to you if transplant is not needed. But patients should absolutely advocate for themselves. If you think you have liver disease, you must absolutely get a referral to a transplant center. The MELD-sodium score, and we talked a little bit about this earlier, the MELD-sodium score is the score that gives listing and organ priority in the United States. So MELD stands for Model for End-Stage Liver Disease. You guys can go online on UNOS and kind of look up the score. Actually, I'll show it to you on another slide, but basically we put in several of your laboratory parameters. There's a long equation, you put it in and it spits you out a score. And the higher the score is, the higher your listing priority is. That also means that you're sicker at that time. And so we use this scoring system in this country because it helps us to ensure that we're transplanting the sickest patients first. And there are nuances to that. Again, we can discuss individually. The transplant evaluation is a 2 to 3 day visit at the transplant center, and you meet all these people that we talked about, the surgeons, the social workers, the coordinators, the financial people, all of that. You do all of your testing and we kind of coordinate it for you. You'll get a schedule, 9 a.m. you're at cardiac testing, 10 a.m. you're here, 11 a.m. So you'll get a FedEx with all of that information there so you know where to go when you have to be there. We do require a social support network, and that is a group of 2 to 3 people. At Emory, we do require 3 people who are committed to your care. Patients often sometimes push back at that because they don't want to impose on other people, impose on other people's lives and schedules, and people have work and childcare responsibilities, and we understand that. The issue is that the data is very clear that if you don't have support, meaning people who are committed to your care, that transplant recipients have a much higher risk of rejection, death, and other complications if they don't have this support network. That data is not in question. It's been known for a long time. And even people as sort of, I use the term loosely, healthy as rich, most people are not like that, and they need help with driving, with bathing, with making sure their medications are parsed out so they can take it at the correct time, getting back and forth. I mean, we require blood test every Monday, Wednesday, Friday for the first 6 weeks or so. So it's a lot. It's a lot of work, and we it's really strongly suggested that you have a group of people that can help you with this. They don't have to be family members. They can be church friends. They can be neighbors. They can be your high school friends. They can be anybody who is committed to your care. And the social workers will go through this with you very carefully. And that's why they're such an important part of our process. We may recommend substance abuse counseling, and this is very individualized. So we have some patients who, may be using alcohol up until a month till they get to a transplant center. Well, that patient clearly does need treatment before they can get on the transplant list. We have substance abuse counselors, and we often refer patients to specific substance abuse centers, depending on their needs. And the counselor, the therapist, the psychiatrist, and psychologist involved with the patient will make an individualized decision for that patient, what is recommended. So it may be an inpatient treatment, it may be outpatient, it may be therapy, it may be 5 days a week, it may be 1 day a week. So everybody is different, and we really defer to our mental health colleagues to help us determine what an individual patient needs. And the whole goal of this is not to be punitive. We have no desire to be punitive. We want to transplant you, but we want to make sure you come out on the other side not returning to drinking or drug use. So very important that we take care of that. We also want to optimize your other medical issues, and I'll go through that in a few slides. But again, if your diabetes is out of control, that needs to be managed, because that problem is only going to get worse after transplant based on the medications that we give you. We talk a lot about diet, exercise, weight control, and protein intake. So diet is very important. We talked about low sodium diet, and we talked about how a nutritionist will help you. Rich mentioned exercise. Even if you're doing a quarter mile, even if you're walking around the grocery store, some exercise is very important to keep yourself in best condition for transplant. Weight control is a big thing nowadays. We all know as a society, our weight is going up, obesity issues are getting worse, and that's actually one of the leading causes. Obesity leading to fatty liver, leading to cirrhosis. That's one of the leading causes for the need for liver transplantation. And we do have to talk about weight control. I have, and I'll give a little more details again in a little bit. And then protein intake. Protein intake is very important. It's recommended while you wait for transplant that you take 1 gram per kilogram of weight. So if you're the average 70 kilogram person, obviously you want to take 70, maybe even a little bit more, 70 to 90 grams of protein per day. So that's very, very important. Remember, we talked about how your body thinks you're in breakdown mode, so you're scavenging muscle. So protein helps to combat that to a certain degree. And then finally, we want to optimize your medications. Sometimes patients get upset when I tell them, listen, let's see if we can get you off some of these sleeping medications and sedatives and pain medications. I'm not trying to make things more difficult for you, and we recognize you have other medical issues, but those type of medications can be very damaging to an already cirrhosis liver, already cirrhotic liver. So when we talk about that, we want to make sure that you're taking the medicines that you need, but kind of optimizing it so you get minimal complications. I saw a patient last week who came in with a list of 32 medications. And when I looked at the list, several of them were of the same class. They were just taking different ones because this patient had so many different physicians. So I immediately knocked off 3 or 4 of the medications because they were duplicates of what he was already taking. And we were able to pare down his list, and he was very thankful for that, because it's hard to take all of those medications and keep them organized. So that's one of the things that we will do as we go through the transplant process. I promised you a the equation, the MELD-sodium score. So if anyone can do this math, I will give them extra credit for that, because I don't do this math. We put it into a UNOS calculator. So go online, Google UNOS MELD calculator. You can put in your parameters if you have access to your labs, and it will spit you out a score. So again, as I mentioned earlier, this MELD-sodium score helps us to assess the severity of your cirrhosis. And it was initially developed in the early 2000s at the Mayo Clinic to see if a patient would have survival after a TIPS procedure. And I'm not going to go over TIPS procedure. That's very individualized. I don't know that anyone here, although certainly we can talk about it afterwards, but it's just a procedure we use to help certain complications of liver disease. But it's an invasive procedure. And so the thought was, well, if we put this into a patient, are they going to live or die at 3 months? So we developed the score to kind of figure that out. But then we also found that it predicts 3-month survival in cirrhosis alone without TIPS. And that was really a breakthrough, because before then, transplant was a little bit, I use the term subjective, meaning, if you were at UCLA and you were in the ICU on certain medications, but then you had another patient in Arizona who was on the same medications, but maybe didn't have some hepatic encephalopathy. How do you choose between those two patients who would get a liver organ? So things really changed when the MELD score became the standard for listing and for assigning priority. And that was in 2002. In 2016, we adopted the MELD-sodium score. And again, that's that equation above. But what we found is that the sodium level also, in conjunction with the MELD score, helps us predict who is going to do well and who is not going to do well. And so since 2016, it's sort of a modified version. We still call it the MELD score, but it's really the MELD-sodium score. And this is very key here as well. So this slide is about the transplant benefit based on your MELD. Again, I'm not going to go into a statistical evaluation, because this is what we teach medical students and residents, but this line here at 1, this represents the break-even point for when the risks of transplant, including infection, death, rejection, all the things that happen, the risks of transplant kind of even out the benefits of transplant that you may get, such as extended life and decreased complication. And what these graphs show is that if you have a low MELD, if your MELD is less than 15, 16, the risks actually outweigh the benefits. So when we see you in the transplant center and you have a low MELD score, I'm jumping up and down, because for me, that means, okay, I know you have cirrhosis. I know you may be having some complications, but hey, maybe I can manage the complications and keep you away from the operating room, which, although transplant is my practice, that's always my goal for you. I don't want you to have to be a transplant recipient. But once the score gets to about 15 to 17, you see how this breaks the break-even point. And that's when we start evaluating you for transplant, because that's when we know, okay, your liver is kind of plugging along. It's not doing exactly what it needs to do. You're having some complications. Here's where it benefits you as the patient to be considered for the transplant list. And so, like I said, it's that kind of break-even point. And then, as you can see, as your MELD score gets higher, clearly you have benefit from transplant in terms of life expectancy and complications. So sometimes patients come in and again, they think, my doctor said I need to get on the transplant list right away. And your MELD score is 12, and you're dealing with a little bit of fluid issues, and I can manage that with fluid pills. Again, part of my job is the education to say, listen, let's see if we can put you on medications and control issues, because the flip side, the risk that you'll take with transplant does not give you enough benefit where you want to consider it at this point. And again, that's my goal, to keep you away from the operating room. Okay, so there are limitations of the MELD score. We hang our hat on this MELD score now, and everybody always wants to know, the first thing they walk in is, what's my MELD score, doc? And so you go over that and you explain it to them, and explain where they are in the list. But there's this concept of the low MELD 6. So that's somebody who has a MELD score of maybe 15, 17, 19. it's not horrible, but as we discussed earlier before I started the slides, the average MELD score in this part of the country to get a liver is about a 29, a 28, 29. So however, that patient with a MELD score of 19 might be very sick. They may have very serious complications with the fluid or the encephalopathy, the bleeding, um, muscle wasting. So all these things that they can be having, they're constantly in the hospital, but yet their MELD score never really goes up high enough. And that's the term that we use, low MELD sick, for that patient. What we found over the years is that the MELD score may not reflect the degree of illness for some of these patients, and it's about 5 to 10% of those patients. And you can speak to your transplant hepatologist, but sometimes what we can do is we can petition the UNOS board for extra MELD points for you. So if your MELD score is 17, but you're in and out of the hospital and you're having one complication after another, maybe I can ask for an extra 3 points, an extra 4 points. Again, it may not get you quite to the level of transplant, but periodically we can ask for more points to kind of put you more in the range for getting an organ offer. So that's something to consider and discuss with your hepatologist. All right, organ offers and organ compatibility. You have cirrhosis, you've gone through the transplant process, you have a medium to high MELD score, you've met all the criteria, you're listed for transplant. Now what happens? So organ offers are given based on blood type. So, you can't give an A organ to a B patient and vice versa. So when we talk about the list, there's actually a few lists because again, it's based on blood type as well. It's also based on the MELD-sodium score. So if you're a blood type B with a MELD of 25, you're on a certain list for your area. There are other considerations. I've been rounding on the floors before, and we have a pre-transplant patient who's next door to a post-transplant patient, and they say, well, why did that guy get transplanted? I've been on the list longer and my MELD score was 2 points higher. I'm not sure how they all know that. I think they must talk in the hallways when they're doing laps, but there are other considerations that the surgeon will take into account. For example, donor size. If there is a donor who's a 300-pound male, but yet the recipient who's listed with a MELD score of 27 is a 90-pound female, physically that's not a good donor for that particular patient. So even though her MELD score may be higher, that donor may go to the next person because you have to be able to size the liver and put it in appropriately. Donor age is important as well. If you have a donor who is age 65, but your patient is age 25, you don't necessarily want to match that. Maybe you would be fine with a recipient who's next in line, whose age is, 68. That makes more sense. The amount of fat in the liver. Recall we were talking about fatty liver disease and patients can get fat in the liver. 1 out of every 3 persons in this country, not you guys, not those that come to my office, but just 1 out of every 3 persons has some amount of fat in the liver. And so when you get a donor offer, when the surgeon goes in to retrieve the donor, they have to assess, is this a really fatty liver? Because if so, that's not necessarily one that we want to take. Some amount of fat is okay. And again, that's a decision that the surgeon makes at the time that he or she goes to retrieve the donor. And then finally, the time of organ donation. There's 2 types of organ donation, brain death, which is typically what we prefer because the organ is still getting a lot of good blood flow. There's also cardiac death. We do use those organs, but those organs can be at a little more risk of complications because by definition, the heart of the donor has stopped. So blood flow has stopped for a short period of time before that organ is retrieved. So again, your surgeons will talk about that with you at the time of organ acceptance. So my point is that it's not, yes, it is based on MELD score and your blood type, but there are other considerations that are important for individuals that the surgeons will take into account when they accept offers for you. Organ allocation has changed, and many of you may know about this controversy. It's a pretty big discussion around the country these days. And we now use something called acuity circles. So in this country, there were certain parts of the country previously that felt that they were not getting good organ offers. So areas in New York and California, their MELD score at transplant was 35, 36. Those were sick, sick patients. And in other parts of the country, the MELD score was in the 20s. So the question came up nationally, why is it that some areas have sicker patients? And there's a lot of nuances to this that we can certainly talk about later. I wasn't planning on getting into, but what UNOS and OBTN has come up with are organ allocation based on acuity circles. So I'll give you a quick example here. If a donor is located here, I believe that's around Cincinnati. First of all, that organ gets offered to any patient within a 500 nautical mile radius that is status 1, that is acute liver failure. That's pretty rare. After that, if there's no status 1, then the organ gets offered in a 150 nautical mile radius for highest MELD. Then it goes to 250, then it goes to 500 again. Typically, a good organ will be accepted within this 150 nautical mile radius. And again, the goal from this was to allow more expanded donation to parts of the country, typically up here and out in California, that were not getting good organs and felt that their patients were dying on the transplant wait list. Now, this was implemented in February of last year, and then COVID hit, and transplant practices have had to adapt to that. So we don't really have the data to see if this has really changed things yet. So hopefully this year, sometime in 2021, we'll have some data to say, okay, this really did help, or no, it didn't help. So we'll have to assess that, but that's still pending. All right, we've gone through all this. You know how organs are allocated. You're listed. What's next? So from my side of things as a transplant hepatologist, I will treat disease-specific treatments. So if you have hepatitis C, I'm going to determine whether I'm going to treat your hepatitis C now. Hepatitis B, liver tumors, all of these things we have treatments for. And I want to see if there's any reversibility in your liver dysfunction. If there is, maybe your MELD score can go from 20 to 15, and maybe we can push off transplant for a while. Again, that's always my goal for you. I'm going to manage overt complications. So if you're having GI bleeding, if you're having, the ascites, the fluid, I'm going to work on those things, and we're going to work together to get you on appropriate medications and diet to see if we can control those. I'm also going to screen you for silent complications. So liver cancer is one of them. Liver cancer doesn't feel like anything. For those of you out there who may have a tumor, it doesn't feel like anything. You can speak to that. But we know that 1 to 3% of cirrhosis patients per year will develop this. So again, people kind of get irritated with the amount of times we put you in the scanner, but this is why we do it. Blood clots can also happen in the veins leading into the liver, and that's very important for us to know because, again, it affects my surgeon's plan for you. And then I will also check you for varices. I don't want to wait for you to come in through the ER throwing up blood. I want to check you and treat you and hopefully prevent that from happening. So these are all things that we do to kind of screen for silent complications. And then we'll also check you for various vitamin deficiencies, other conditions that we know that go along with cirrhosis. And vaccinations are a key to help keeping you healthy as you wait. We're going to look at various other medical problems. We talked about obesity. We do recommend weight management. I wish I had a way to show you. I'm not sure if you can see, but if a surgeon has to go in like this, as opposed to this, to do your transplant, you can see how technically it's more difficult to sew when you're like this, as opposed to when you're like this. And hopefully that makes sense. But if a patient is very obese, that can technically pose problems for the surgeons. Tobacco is a hard stop. Cessation is required because there's a high risk of clotting off. Hepatic artery thrombosis is a clot that happens at the hepatic artery. And of course, there's other risks associated with tobacco use. And then we'll screen you for heart disease. We don't want you to have a heart attack on the operating room table. We need to treat that prior to getting listed. In fact, I had a patient yesterday who was getting a pre-transplant stress test that was very positive, and I sent him immediately to the cath lab because I want him to get treated so that we can list him. Um, Portopulmonary hypertension, again, this is something that we all will take care of, but if you are having troubles with shortness of breath, we will be evaluating you for this. We also need to screen for cancer outside of the liver. People can have, endometrial cancer or prostate cancer. We need to get that cured and treated so that it doesn't interfere with your transplant candidacy, because the worst thing in the world is having an unrecognized cancer and you transplant that patient. What happens? We immunosuppress you and that cancer becomes very aggressive. So we've really not done you any favors by doing this. So we require that you get your colonoscopy, your mammogram, your pap smear, just all of the things that we should be doing anyway in our healthcare. And that is to make sure that there's nothing else going on. Kidney disease is a big problem. And so if somebody has chronic kidney disease related to diabetes or high blood pressure, sometimes we have to consider patients for simultaneous liver and kidney transplants. I would say about 10 to 15% of our transplants at Emory are simultaneous liver and kidney, because kidney damage is a common outcome. And if you have kidney damage and you have kidney failure after a liver transplant, there are poor outcomes. So we want to identify that before so we can talk about a simultaneous liver kidney transplant. There's lots of infectious diseases that can affect patients both pre and post transplant, and that's why we have a very strong team of people who will help screen you for these conditions so that we can treat you appropriately. I won't spend too much time on hepatopulmonary syndrome, but if you are a patient that has low oxygen levels, yes, it can be related to your liver disease. And so we will evaluate you for this condition. And if you do have it, in fact, we can get you extra MELD points because we know that these patients have a higher risk of 3-month death, 3-month mortality. So again, during your evaluation, we check you for all of these things. Finally, there are some surgical considerations, frailty assessment, nutritional assessment. And I referred to this earlier, so I won't spend too much time, but our surgeons need a roadmap. They need to know what surgeries you've had before. They need to know if you've got clot. They need to know if you've got liver cancer and how it's been treated. And all of this plays together in their plan of how they're going to perform what we call the hepatectomy, which is taking out your old liver and placing the new liver. The psychosocial evaluation is also important, and there are things that the psychiatrist and the social workers look for. Adherence with medical therapy. If I have a patient who has gone to 5 different doctors and never really completes any treatment and doesn't take their medications, that's not somebody who necessarily is going to do well post-transplant. So we want to make sure you complete your evaluations and do your follow-up. Our social workers will talk with your support group that you have established to confirm that they have commitment to it and commitment to you. We evaluate and treat psychiatric comorbidities. Again, we talked about anxiety, depression, PTSD. These things can happen post-transplant too. So we want to have you have a longitudinal relationship with our team. We look at the risk of alcohol and substance abuse recidivism, a statistic that's not well known out there, but is about 20% of patients go back to drinking alcohol. That's a heartbreaking statistic for me, and I'm sure for you all as well. So we try to help those patients and give them the best possible chance at good outcomes. And patients who are on methadone do not have to stop it. It used to be that we would make patients stop it, but we recognize that that's not necessarily in the best interest of the patient, so it's not a contraindication. Just 1 minute on living donor transplant, and others may have questions, but living donor transplant, the way that I like to think of living donor is that the patient that I think that would be a good candidate is somebody. Recall we talked about low MELD-6. So MELD score is 20, never really going up higher than 20, 25, which is borderline for even drawing an offer from the traditional way. But yet they're sick. They are chronically sick. They're in the hospital. They're having one complication after another. They're losing weight. That's the type of patient where I think they would be a good candidate for living donor. They cannot be obese. They cannot have any blood clots, and they have to be a candidate for traditional liver transplantation to be a candidate for living donor. I'm often asked about donors. So a donor has to be also somebody who is quite healthy. They cannot be obese. They cannot have other major medical problems. They traditionally have to be young, less than 50 years old. The blood type has to match. The size has to match. Again, remember that example I gave you guys before. And there can be no coercion for the donor. So there should be no financial coercion, no work-related coercion, nothing. The donor should not be receiving anything in contribution for donating part of their liver. And so we have a whole team of people that will evaluate this to see if the donor is truly a good altruistic donor and has no expectations in return. But this is a good way to treat a patient who is not drawing organ offers, but it continues to get sick. And outcomes are very good with living donor liver transplant. And then one final slide, and I'll open it up. We have some time to talk on COVID-19 and liver disease. I know patients have a lot of questions about this. So we do know that adult patients with cirrhosis who contract COVID-19 disease, they have an increased morbidity, which means increased complications, oxygen need, frailty, hospitalization, et cetera. And they also have increased risk of death. So please, it's very important that even though vaccinations are out, it's very important that you continue to protect yourself with masks, making sure you and those around you get vaccinated, and being very particular about where you're going still right now. The data suggests that vaccine efficacy is the same in patients with cirrhosis and those without cirrhosis. And that's a little bit of extrapolated data because they don't talk specifically about cirrhosis. They just talk about patients who have chronic disease, and cirrhosis is part of that. And again, the vaccine efficacy is the same. So you should receive the vaccine if you are amenable to that. Patients who have chronic liver disease and cirrhosis who are on treatment, for example, if you're getting treatment for Hep C, if you're getting treatment for autoimmune disease, take all of your medication while you're taking the vaccine. You shouldn't stop and start things while getting the vaccine. And then finally, if you're listed, you're a liver transplant candidate, it doesn't matter what your MELD score is. And even if you receive only one dose, get your first dose to ensure as adequate an immune response as possible. With the first dose, people are getting about 75% protection. The second dose confers about 95% protection. So even if your MELD score is 30 and you think you're going to get an offer tomorrow, get your vaccine, and then our transplant infectious disease team will determine when you get your second vaccine after transplant. But go ahead and get that. So in summary, patients with decompensated cirrhosis or anyone with uncontrolled symptoms and a MELD greater than 15, please be referred to a transplant center to get evaluated. We do things in a multidisciplinary team effort to identify those patients who could benefit from transplant. Living donor is a great option to avoid prolonged waiting time, and if the MELD score is not increasing appropriately. And again, it's an associate with select patients. And when you come to us, any of your hepatologists, we aim to optimize your medical condition to ensure the best possible post-transplant outcome like Rich has had. That's what we want for all of you. So I thank you for your time. I hope I didn't give too many details. I can stop sharing, and I'm happy to answer any questions that you guys might have.
Thank you so much, Dr. Reshamwala. I am happy to also open up for, like, if you would like to unmute yourself, I will keep Dr. Reshamwala spotlighted, so only the video will be on her, but your voice will show up if you'd like to unmute and ask a question, or you can also type it in the chat box, and I will be happy to read the question if you don't feel like speaking today, which is also welcome. I'm sure somebody has a question.
I have a question.
Hi, sir.
Hello. I am a liver recipient, and I got a call. Well, I've been on the list since July of last year. Got a call in January to come in. Showed up. They told me later it was what they call a dry run. does that mean I'm any closer to getting a liver, or is that just a fluke, or what?
Yeah.
How will I ever know the reason for that?
Yeah. So what likely happened, I'm kind of extrapolating, but what likely happened is you are up there. Your MELD score is up there. So
Right.
they had an offer, and they thought you might have been, now there might, as I mentioned earlier in the talk, there might have been a person or two ahead of you, but they might have thought that you would have been a better recipient based on various characteristic of that donor. So they called you in, but what may have happened is that the surgeon went to go retrieve the liver and they looked at it and they said, oh, it's too fatty, or it's not a good liver, or we found some other problem with the donor. So that's typically what happens at our center. But what that does mean for you, that's hope. Rich was talking about hope. That's hope. That means your MELD score is up there. That means your name is popping up on match runs. So I would take that as a very positive sign. And
Okay.
we do use that term dry run. I don't like it because typically there was an offer for you. So it's not like it was just fake and they brought you in. But the average at our center, the average number of times a patient comes in before the organ is accepted and it's a good organ is 2. So I wouldn't be surprised if you have another one of these.
Okay.
Yeah, but that's a good thing for you.
All right. Thank you.
Very welcome, sir.
All right. Are there any more questions? Well, you covered it all, Doc. Oh, yes, I can hear you, Regina. Go ahead.
Yes, Doc. I have a question for you, please. I'm listening, and the MELD score is what kind of is concerning for me, because actually I did everything that the doctors asked, and I'm doing healthier and better. And in my case, yes, mine was alcohol. I don't mind to share that. And I've been into my recovery and my meetings, not meetings with the one counselor. She's great, Dr. Tarver. But to get to the point, I actually 6 months ago was all the way down to a 9. So I'm just curious that if I stay on this right path, stay on this right track, is there a possibility that is that something to worry that because it's down and I'm doing good, that it jumps back up as long as I stay on track?
Ms. Simpson, that is a great question. Thank you for asking and thank you for sharing. One of the things I had said earlier is you're right. As patients are in recovery, their liver function absolutely does get better. So I'm so happy to hear that your MELD score is down to 9. I'm sure it was higher before. So
Yes.
I have had many patients who their MELD score goes down to 9 and they stay that way for years. I mean, I have one guy I saw last week who I've been following for 15 years, and he's been sober for 15 years and doing well and not needing transplant. The issue with liver patients, with cirrhosis patients, is that something can tip them over the edge. So heaven forbid, but say you get a pneumonia. Something that has nothing to do with your liver can tip your liver function over the edge and make your MELD score pop up again. So the importance of you following with your hepatologist is highlighted here because you've done everything right. You're doing great. We could be talking 10 years down the road and you get some other problem and again, it kind of tips your liver over. Then at that time, you may need transplantation. But as of now, I have every expectation based on what you're saying that you're going to continue to do well, keep a low MELD score, continue with good nutrition and not need surgery, which is, as I mentioned, always my goal. But yes, you must continue to follow because things that are outside of your control can tip over your liver function, and you want to be able to have that backup of transplant if needed. Does that answer your question?
Okay, great. Yes, ma'am. Thank you so much.
Thank you.
All right. Any last questions before we end? I don't want to forget. I don't want anyone to forget. We're going to actually rejoin the other session for informal just discussion if you want. Last time we went over by almost an hour with just general discussion in a informal way. So so don't leave if you want to stick around for that. But thank you so much, Dr. Reshamwala. We really appreciate you today. I'm going to go ahead and stop the recording.
Thank you, everyone. Great to see you. Good luck on your journeys.